Good afternoon. This is Barbara from the Department of Medicaid Services. I am still clearing the waiting room.
Hello, folks. Welcome. I have to change my name so you know who I am.
Almost didn't recognize you, Dr. Schuster.
Yeah, for some reason, Zoom keeps wanting me to be a friend who lent me her Zoom. Um, let's see. We've got lots of people on.
We have Valerie.
Okay.
I was looking for TJ.
Yeah. Misty said she would be on, and Tara.
Yeah,
Steve Shannon is
out.
in Belgium right now.
Oh,
And of course, Mary is gone and we don't have a replacement yet.
okay.
So
So we currently have Valerie. We're waiting for Misty. And you said Tara, correct? I don't see
yeah,
Tara on here.
Misty and Tara and TJ.
And TJ. Should we give him a few more minutes?
Yeah, let's give them a couple of minutes. Let me see. I might be able to text them.
Let me go in and check that waiting room. Okay, I see Misty coming on,
Okay.
and I see Tara coming on.
Oh, perfect. Okay.
Okay,
Yeah. And so we have a quorum. Let me see if I can find TJ.
so we have Tara, we have Misty. I'm still waiting on TJ. I also want you to know, Dr. Schuster, I made Michelle Sanborn a co-host.
Okay, great. So that she
Mm-hmm.
can share her screen when she's ready. Wonderful. Thank you, Barbara.
You're welcome.
And this is your first meeting with us, right?
Yes, it is. It's actually
Okay.
just my second meeting doing this alone, but TJ's
Oh,
on. I just
okay.
saw TJ come on. So the waiting room is clear if you want to begin.
All right, wonderful. So we'll call the meeting to order. This is the Behavioral Health Technical Advisory Committee for September 11th. This is when you're on the runway and the pilot says, if you're not going where I'm going, you're on the wrong plane. So hope that you all are on, and uh, let's have our voting members introduce themselves. Misty, I think you're on.
Hi, afternoon. I'm Misty Agney. I'm with Fraser Rehab Institute and the Brain Injury Alliance of Kentucky.
Great, thank you. And Tara?
Everyone, I'm Tara Hyde with People Advocating Recovery and Person in Long-Term Recovery.
Wonderful, thank you. And Valerie?
I'm Valerie Mudd with NAMI Lexington and Participation Station and represent a person living with mental illness and in recovery.
Great, thank you. And TJ Lidovic?
Let me check to see if TJ is muted.
Okay.
All right. I just asked her to unmute. There she goes.
Yeah.
Am I good now?
Yes, you're good now. Thank
All
you.
right. TJ Lidovic on behalf of NAMI Kentucky.
Wonderful, thank you very much. And I forgot to introduce myself. I'm Sheila Schuster, a licensed psychologist and representing the Kentucky Mental Health Coalition and your erstwhile chair. And I'd like to welcome Barbara Wash, who is our new facilitator, having been, I guess, initiated to this by Aaron Bicker, who was our facilitator for many years. So we welcome you, Barbara, and are glad to have you helping us out here.
Thank you.
All right, first order of business is approval of the minutes, which were sent out, probably several copies because I had the internet gremlins were going after my emails, but I would entertain a motion from one of the voting members to approve the minutes of our July 10th BHTAC meeting.
So moved.
All right, Val, and do I have a second?
Second.
Second, TJ, thank you very much. Any additions, corrections, omissions? All those in favor of approving the minutes signify by saying aye.
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 All right, and opposed, like sign. Thank you very much. I've kept the next item on the agenda because the resumption of prior authorizations has not really been underway too long, really got underway July 1st. So I wonder if, and Leslie, I don't know who from DMS might be in a position to talk about this.
Yeah, do I have Sherry on or Angela Parker? Angie Parker,
Okay, great.
just double checking. I'm not
I'm
sure who
here.
we have today. Okay, do you want to give an update on that?
Well, other than what Dr. Schuster's already mentioned, it's been in place at least since July 1st for most MCOs, and I think some of them went back to from June 25th. I do know that there was a meeting with Kentucky Hospital Association with each of the MCOs a few weeks ago that I think they were able to come to an understanding of what some of the challenges were. I haven't personally heard anything since that meeting, so I'd have to defer to any other providers who are potentially experiencing any challenges, any additional challenges or continued challenges.
All right, thank you very much, Angie.
Mhm.
Are there any providers on that are encountering anything that they'd like to bring up
This
at
is
this meeting?
This is Michelle Sanborn with the Children's Alliance. We've had a couple of things come up that we're concerned about. One is two of the MCOs has told one of our members that they have 5 days to respond to the prior auths. And while that might be a appropriate amount of time for certain services, 5 days is a lot for some of the emergency type services and the urgent services that our behavioral health providers and substance use providers are providing. And so we just didn't know where the 5 days rule came from and what that's about. Angie?
Yes, Michelle. And I believe, and I do have a PowerPoint that addresses timelines. So I believe Verona, our Senior Deputy Commissioner, Veronica Judy Cecil, had mentioned last time that if we could present some of this information. So if you'd like me to go through that now, I can do that. If Barbara, if you give me access to the.
That would be great, Angie, thank you.
So I'm going to stop my share and you'll be able to share from your screen. Okay, Michelle?
Oh, it's Angie.
Oh, I'm sorry, Angie.
Okay.
Okay. Hold on, Angie. Let me get you as a
Angie Parker.
co-host.
Yes.
Angie, I'm sorry. I'm going to
It's
make you a
going great, Barbara.
co-host. There you go. And I'm going to stop my screen.
All right, thank you, Barbara.
You're welcome.
Okay. It looks like everybody can potentially see this.
Yes,
If I can get it. Well. All right, well, I'm just gonna go, well, that's not the way I wanted it either. There we go. All right, so today is September 11th, as we remember, 24 years ago. But as far as I wanted to really kind of talk about what managed care utilization program, what they are required to do federally and state statute. So each MCO must have a utilization management program that meets the requirements in the contract, the MCO contract as defined in this statute. Program process and timeframe shall be in accordance with this CFR that's listed here. If a contract with a private review agent, as defined by this KRS, and that agent is to comply with all applicable requirements of that statute. Just so you know, whichever is most restrictive, federal or state, that is the timelines or timeframes that they have to go through.
Okay.
And the MCO's medical director and behavioral health director are to supervise the program and should be accessible and available for consultation as needed. So what are the timeframes? So you look at a standard, which is considered non-urgent, no later than 5 days of receiving the necessary information for the request. So that's probably where the 5 days comes in. And I will be going over what necessary information is on the next slide. A standard authorization decision may have an extension to the timeframes of up to 14 additional calendar days if the enrollee or the provider requests the extension, or the MCO justifies a need for additional information and how the extension is in the enrollee's interest. So 5 days is the norm, but if 14 additional days can be provided if requested by the provider or the MCO feels like the additional information would help in the determination of the authorization request. Any retrospective review means after the service has occurred, review is within 5 days, and it doesn't specify business days or calendar days. But it can be also within 14 days if the enrollee or the provider requests an extension. This is the same for retrospective review, because at that point, it's probably could be considered non-urgent. Although when you think of an inpatient admission that occurred on the weekend and you don't hear about it until they don't get a request for the authorization until Monday, that still could be considered an urgent admission.
Right.
So the necessary information, what is the necessary information? It's limited to the results of any face-to-face clinical evaluation, any second opinion that may be required, and any other information determined by the department to be necessary to make a utilization review determination. Now, this is language from the KRS 304.17A-607. Expedited, which would mean urgent. An authorization request should be completed within 24 hours after obtaining all necessary information to make the utilization review decision and provide notice as expeditiously as the enrollee's health condition warrants. Substance use disorder primary diagnosis is considered an expedited authorization and should be provided within 24 hours of notification.
So in Michelle's case,
Mhm.
Michelle, I'm guessing that you're talking about cases that you would see as being urgent or expedited.
They were substance abuse. The one that was concerned about this were substance abuse disorder, residential treatment provider. But I mean, is PRTF considered urgent? Because I mean, that's waiting 5 days for a prior auth for a placement in a PRTF just seems like a long time when these kids need placement like ASAP.
I think it depends on the situation, Michelle. If you don't mind me calling you Michelle.
Yeah, no, please. Okay.
So there's no hard and fast rule like there is here for the SUD diagnosis for any other automatic one.
That's correct. So if I think it's relevant to the situation that you have, what would be considered expedited or considered urgent. It should be provided within 24 hours for a substance use disorder.
Can we have
Yes, it-
access to this slide deck when you're completed,
Absolutely.
Angie?
Yes,
Thank you.
ma'am.
Yeah, if you'll send it, Angie, to Barbara, we'll post it and get it out. Thank you.
Mhm. And then the last slide, it addresses the peer-to-peer that we often hear about. Peer-to-peer is not a Department for Medicaid Services requirement. However, we do highly encourage our MCOs to do this, which the last bullet point does state that each Medicaid managed care organization has a peer-to-peer policy. A peer-to-peer is initiated by the provider prior to a formal appeal of the prior authorization denial. Peer-to-peer should occur before the prior authorization denial is finalized. If the peer-to-peer review does not resolve the issue, the provider or member can file a formal appeal. Because this is not currently a DMS requirement, we are looking at all of the MCO policies to see if there should be any potential contractual obligations to this policy of each MCO. Because I know we have heard that some providers or one MCO does this and one MCO does that. So we are evaluating that.
Okay. Yeah, I would think that it would be really helpful to providers if there was a consistent requirement. And is peer-to-peer defined as to what constitutes a peer? Because I know that question has come up before.
That's a good question. I think I have seen, it should be someone, I believe it's somewhere addressed of the persons who should be reviewing any denials would be the same definition. They would have to, like for a substance use disorder provider, would have to talk to a substance use disorder provider on the other side as well.
It'll be interesting.
What
if
may
you're
be
gonna-
easier for me to say is if a primary care doctor would talk to a primary care doctor, that's what those.
Yeah, and I think that's what we've requested on other things for a psychologist to talk to a psychologist kind of thing. And we've run into issues, I think, on appeals where the person that was put out there by the MCO is in another state and doesn't have the same, sometimes the same services, the same
Mhm.
requirements for services, and that gets to be a problem too. So I encourage you all to look at that as you're reviewing the MCO policies, please.
Absolutely. And this is the last slide I had on this. I just a real quick overview of prior authorization requirements.
Excuse
Yeah.
me, Terry, this is Barbara. We have a question in the chat. When will availability load bypass codes for dual eligibles? This
That
came,
question, yeah, that question came up at a previous TAC meeting. Terry Wilson, if you on, you want to add something? You know, we worked with the we worked with the MCOs to get that list of bypass codes. That's what you're talking about, Terry, isn't it?
That's correct, Sheila. Our billing staff are still having to fax in for members who have commercial and Medicaid. There, just to let folks know, there was a bypass list that was created, I believe, by Humana, or the effort was spearheaded by Humana to make billing easier. And for authorizations, we're not able to use that bypass list yet. We're having to fax in to the payer rather than use Availity. So the question is, will Availity get that bypass list to make prior authorizations easier?
Yeah, Angie, you may remember how many BHTAC meetings we spent talking about dual
Yes.
eligibles
I
and so
do remember.
forth.
That's been a while ago.
That's been a while ago, and Humana did spearhead that, with all the MCOs contributed to it, and they did come up with a bypass list. But if it's not available except by faxing it in, that would seem to be a delay. Can you check on that?
Yeah, I haven't, that would probably be more of a MCO to MCO issue. But certainly we can look into that.
All right, thank you very much.
Mhm.
And thanks for the PowerPoint. I had not made a note that you all were going to do that, so appreciate um, Senior Commissioner, Senior Deputy Commissioner Veronica Judy Cecil, that's a long thing, preparing that with you, and I appreciate your sharing it with us.
Absolutely.
Any other questions related to prior auths? What about audits? We have any issues there? Somebody was on last time for Jennifer Judinsky and answered some questions, and I keep this on here because I keep hoping that as prior auths are initiated, that we will see fewer audits. And we were told at the last meeting that the number of audits had been reduced by DMS, I think, for targeted case management. But do any of the providers in the audience have any questions or issues around audits?
Hi, I'm sorry. I jumped in a little bit late, but we had actually a question regarding targeted case management as just what exactly is the date that prior auth became necessary for TCM? Because we've gotten it, we've gotten a letter from one, we've gotten a letter from the other. Is that something that is decided like universal, or is that something that's like per the MCO or per Medicaid?
Well, I think what happened was that because TCM is billed monthly, and the start date for the prior auth was June 25th, which didn't fall at the end of a month. There was a big debate in the BH TAC actually. And I thought that all of the MCOs had decided to start the prior auth for targeted case management on July 1st. If that's incorrect, I'm sure that some of the MCOs on here will correct me, but I thought that was what the conclusion was. Have you gotten anything other than that?
We like just in August started getting kickbacks. And so that does make sense, that July 1st date, but I just wanted to confirm that on here.
Yeah. And who are you with, Marissa?
I'm so sorry. I'm from Altieri Behavioral Health in Lexington.
Okay, thank you. Nice to know where people are from. Thank you.
Absolutely.
So, yeah, I think July 1st is the answer to that, if that makes sense. Okay. Thank you for that question. Nothing on audits?
Well, I hate to be the bearer of bad news if no one else is going to say anything, but yes, audits keep coming. And our most recent, and I think this was mentioned last time or a couple times ago, that UHC is now somehow they've determined that autism is not a severe mental illness. And so we had gotten a couple of calls about that, and now we have an audit, and everybody in the audit is someone who was receiving case management or TRP services who have a diagnosis of autism. So in addition to just all the other audits that just keep coming, I would say a couple a month, sometimes every week we're getting them. Now it seems like that's going to be an issue, and I'm really concerned if we decide that autism is not a severe mental illness.
And who are you with, Susan?
Children and Family Counseling Associates.
Okay. That's a good question. I don't know the answer to that. And who makes that determination?
So this is Liz Stearman. I don't want to speak out of turn. I'm the behavioral health director for Humana. We can provide some guidance. However, we are required to use the DSM and standard diagnostic criteria. I'm seeing Dr. Mark shaking her head, so I'm hoping she may jump off here. So severe and persistent mental illness or severe mental illness is very specific diagnostic codes and areas. I believe typically we consider autism to be within the developmental diagnose or disorders, and severe and persistent mental illness is a specific category that gets defined clinically. So I don't know how much detail we want to go into here, but I don't believe we would consider from a coding and clinical review perspective, autism to be a severe and persistent mental illness by category.
Yeah. Did you
Dr.
say?
Schuster, this is Stephanie Koenig with United Healthcare. Can I speak as well? Thank you, Liz, for jumping in. I'm happy if we can address this, as Liz said, or I'm happy to take it offline and we can further have conversation about our medical decision determination based on the questions that have been raised for United Healthcare.
But I'm assuming, Stephanie, that you all are you putting autism spectrum disorders in the IDD category?
That is correct.
Okay.
Yeah, there is a severe mental illness checklist that DBHDID posts. Yeah. Oh, it's already in the chat. Sorry.
Okay.
Dr. Schuster, I don't want to speak for the I'm sorry. I don't want to speak for the MCOs either, but it's my understanding there was some recent change to the interqual criteria as well, which is a standard that some of the MCOs are utilizing as well. So, Liz, I don't know if you can expand on that. I believe that was another issue that we had, that the criteria is better reflected in the interqual criteria now.
Yeah, so as an MCO, obviously we're beholden to the departmental documents and guidelines and also the definition of SMI that's in regulation. We at Humana don't use interqual, we use MCG. So I definitely would step out of that discussion, but yeah, maybe that might be something for an offline one-off call.
Sure. Yeah. And I know that you're held accountable to use some type of tool, right, to evaluate.
Yeah.
And I knew that some did use interqual, and I had just heard that recently from some of the, actually from an ABA advocate.
Yeah,
Sure. And I think to say for ABA specifically, you're right. Historically, ABA has been restricted to only autism. There is some medical necessity criteria expansiveness for ABA. I did not hear in this, I think we were talking about severe mental illness as it relates to targeted case management, maybe some other services. ABA and autism very closely tied. I think the concern maybe expressed here was services that are designated to be delivered to individuals with severe and persistent mental illness, that autism would not qualify for those services. And I think that is probably accurate. Yeah.
Yeah.
Hi, this is
targeted
Dr. Kelly.
case management. Yes.
Hi, I'm the new CMO for Molina, and I happen to be a child, adolescent, adult psychiatrist. But I would just mention that in DSM-5, it's defined as a neurodevelopmental disorder. And that's not to say that it's not accompanied by an SMI illness at the same time. But just by definition that, but autism is quite severe, as you know, and needs ABA therapy and is accompanied by other mental health disorders often.
Yeah, thank you for that.
If that's helpful.
Yeah, thank you for that, Dr. Kelly.
So just to clarify, what I'm hearing is that for individuals who have an autism spectrum disorder, case management is not a service that can be provided for adults anyway.
If the person is in a waiver, all people in 1915C waivers have case management, not targeted case management. So anyone in a waiver would be eligible for case management, but outside of a waiver, they would need an additional SED or SMI diagnosis for targeted case management.
Yeah, I think the distinction is case management versus targeted case management, right, Sherry? I mean, targeted case management has always been reserved for SMI.
Several of the folks that we are talking about, they're on the wait list for Michelle P. waiver. And they have been for years, but they don't currently have a waiver. So they've been receiving targeted case management.
And their diagnosis is autism spectrum disorder.
Correct.
Yeah, I think that I think the feedback that you've gotten from UHC and the discussion here would suggest that they probably are not eligible for targeted case management until, unless they also have, as Dr. Kelly pointed out, you could have a primary diagnosis of autism spectrum disorder, but you could also have a diagnosis of severe mental illness. Good discussion, and I'm really glad that you brought up that question. It should not affect the provision of ABA services, however, but you mentioned also TRP, right?
Correct.
So, and I don't know, is TRP a service that typically would be available to folks on the autism spectrum disorder who are not in a waiver?
The same criteria and regulation about the diagnosis.
So they would need to have an SMI diagnosis.
A primary mental health diagnosis.
Mental health diagnosis. Okay. Okay. I mean, a lot of you know that I haven't been in clinical work for a long time, but it's certainly in the early days of autism, we always saw it as a intellectual developmental disorder, neurobehavioral disorder. Susan, if you have any further questions, I would see, you can email me if we need to keep this on in a future meeting, but it sounds like the rules and criteria are pretty clear.
Thank you.
All right, thank you. Let's move on to the MOAB, that infamous Medicaid Oversight and Advisory Board. And Steve Shannon and I serve on the MOAB. We both serve as citizen members, which means that we have a voice but not a vote. And I serve as, because I'm the chair of the Medicaid Advisory Council, now called the Medicaid Advisory Committee. And Steve was appointed along with another citizen by House Speaker David Osborne. Senate President Stivers could appoint 2 people, and Osborne could appoint 2 people. So we both serve on the MOAB. So the July 30th meeting was the second meeting of MOAB. The first meeting in late June was really an introductory meeting with Stephanie Bates, who now works for the Legislative Research Commission, used to be with Medicaid, giving an overview PowerPoint. And the July 30th meeting had 2 very interesting discussions. One was an update by Catherine Costanza from the National Council of State Legislatures, called NCSL, who did a good overview of all of the federal changes to the Medicaid program, of which there are many. And as most of you probably know by now, a lot of those changes are spaced out in time. There are very few things that are just going to happen immediately. Probably the most immediate is with our folks who get qualified health plans from Connect, and the subsidies that have been part of the Affordable Care Act that created those programs are due to expire at the end of 2025. And the concern is that the premiums for, I think there's 90,000 Kentuckians who get their coverage that way are going to, in some cases, double or triple. So there is still time for Congress to act to extend those subsidies. And you all probably are getting some action alerts around that. The other presentation was by Nancy Galvani, who's the president and CEO of the Kentucky Hospital Association. And it was requested because of the report that was put out by the Kaiser Family Foundation based on some research that was done at the SHIP Institute in North Carolina that listed, I think, 350 hospitals, rural hospitals across the United States that would be at risk of closing if HR 1 passed, which of course, as you know, it did. What's interesting is that Kentucky has 2% of the population of the United States, but we had 10% of the hospitals that were listed in danger of closing. We had 35 rural hospitals. And that list is available. It's been bandied about quite a bit, but if you live in a rural area and you have a hospital, that hospital's probably on there. And I think the criteria were that they were either operating in the red or were barely being sustainable for the past couple of years. So Nancy had, in some ways, a positive message saying, number one, that the most egregious cuts were not going to come immediately. Number two, that she didn't feel like that those hospitals were going to close. You know, you create health access deserts that are just incredible if you close those hospitals. You also lose, if all of those hospitals closed, I think 20,000 jobs, everything from the physicians at the hospitals to the clerical to the janitorial staff and everybody in between, and a huge hit to the economy of those towns and counties where they're located. What she did say, and I think this is an important message for all of us in behavioral health, she said it's most likely that hospitals will cut those services that tend not to be moneymakers, essentially, or, you know, on which they don't always break even. The number one being maternal health, OB services. And we certainly are seeing that even in Louisville, where two hospitals, Peace Hospital or U of L Hospital, not Peace, but U of L hospitals and Norton were both going to open new OB clinics, one in West Louisville and one in Southwest County. And both of them have closed down those projects because of the concern about the funding coming down the pike. So number one was maternity services. Number two, and she said this several times, were behavioral health services. Now, a lot of these hospitals may not have actually a wing or beds put aside for psychiatric care, but it also impacts, and her number three thing was the emergency room. And we know that we have a lot of people that end up in crisis going to their closest hospital in the emergency room and then needing to be transported to a hospital that has psychiatric beds, which is an issue that we have thought about because the ambulances very often refuse to take our people to those hospitals. So that was the July 30th meeting. The August 27th meeting had lots and lots of testimony from the Department for Medicaid Services. So the topics were state-based marketplaces versus the federally facilitated marketplace, the role of connectors and navigators, a discussion of presumptive eligibility, then a general discussion of Medicaid eligibility, enrollment, and redeterminations. And then finally, an update from Dr. Stack, Secretary Stack, on the Rural Health Transformation Program application. certainly appeared to me in the line of questioning that a lot of the legislators thought that state general fund dollars were being used to support Connect, which was not the case originally. That was federal funding that set up the state-based exchanges, and is not the case now. It's funded in part by fees paid by the MCOs. And the argument from the state, from DMS, to keep the state-based exchange versus the federal exchange is that the federal exchange only takes applications for the health benefit plans. It does not look at an application to see whether the person is eligible for Medicaid in their state. So the argument from DMS was that Connect is a one-stop shop, that you make an application and you might get one of the health plans on Connect. But first you're looked at in terms of whether you're eligible for Medicaid, whether your children are eligible for Medicaid or for K-CHIP. It also looks at eligibility for SNAP and LIHEAP and some other public safety net programs. There was an interesting discussion about connectors and navigators, and they had several agencies across Kentucky, Community Action, the Kentucky Primary Care Association, and one of the ad districts, KIPTA, the Kentuckiana Planning and Development Agency, who all have contracts with the state to hire and train navigators and connectors. And so there was a lot of discussion about what they do, their role in trying to get people into coverage. The legislators, I think, again, wondered about how much money was being spent on that, and I think got, accurate information from those agencies. Presumptive eligibility is can only be granted in the hospital, and that was explained by people from KHA. And what happens if somebody presents at the hospital and they don't have any insurance and they need services, and the hospital is obligated to give them services. So they have if they don't have a connector or a navigator, they have an enrollment specialist who looks to see, and they can, if they look like they might be eligible for Medicaid, they can serve them under presumptive eligibility. So that was the tenor of the questions. I think the legislature is rightfully concerned about the cuts in federal funding for Medicaid, and we're coming into a biennial budget session in 2026. So they're looking to see whether there are places that we are spending money on Medicaid services and, that doesn't need to be spent, basically. My impression was that DMS did an excellent job in talking about the services that were available and so forth, and what the actual cost was in state general fund dollars. Dr. Stack gave a brief report on the Rural Health Transformation Program, which was put in HR 1. It's $100 billion, $50 billion. Spread over 10 years, and every state that applies will get some portion of it, but then there will be some states that will get grants. And so there is a very tight timeline to submit a grant from Kentucky that is transformative. The money cannot be used to replace loss of federal funding or for direct clinical services. So they're really looking to, was kind of a buy-off that the Congress offered some of its members who didn't want to vote for HR 1 and were concerned about the impact on their rural hospitals. And so it's not designated necessarily to all go to hospitals, but that was certainly the impetus for it. And then finally, on Tuesday, we had another meeting in Moab, and it was solely on the 1915C home and community-based waivers. So Dr. Hoffman and Carmen Hancock presented an overview of the 1915C HCBS waivers. And then Steve Shannon and Amy Stade with the Kentucky Association of Private Providers gave a very short presentation, but a powerful one on from a provider's perspective. Amy looking at the rate study that was done and was not fully funded to increase the rates for those personal service workers. And Steve really reprised the work that he did 2 years ago for the budget session in trying to get rid of the waiting list. You all may remember that when we made that push, the waiting list for the HCB waivers was about 13,000 people, and we got more funding. They funded 1,925 slots in that budget session, when typically we've had several hundred slots funded. But unfortunately, the waiting list for the waivers is now up over 16,000. So we're going the wrong direction. So Steve has a plan to reduce the wait in 8, meaning get rid of the waiting list for those Michelle P. SCL HCB waivers, which are the ones that have the biggest waiting list in 8 years. Deanna Gordon, Representative Gordon, had a brief presentation on a bill that she's going to file next session, trying to get a Medicaid waiver for essentially assisted living services that could be delivered in the community. Again, with the idea of keeping people out of nursing homes and other facilities. And then an interesting presentation from UK by Mark Birdwhistle and U of L from Ken Marshall on how they have used their state-directed provider funds and their quality measures, and really touting the improvement in health that they have seen. So one of the things I will note is that they have added a 15-minute public comment period at the end of each MOAB meeting. You have to be there in person, you have to sign up in advance, and the speakers get 3 minutes. So at the most, we hear five minutes. And I think that will lead us into a presentation that Michelle Sanborn gave, not on the agenda, but as part of the comments, public comments. So Michelle, take it away.
Thanks. Can you see my presentation?
Yes.
Perfect. The Children's Alliance wanted to make 2 recommendations to the Medicaid Oversight and Advisory Board. The first recommendation we made was to require Kentucky fee schedules to be posted no later than March 1st of each year for an April 1st implementation date. Because this year those rates weren't posted until July 15th with an April 1st effective date. So, having to go back and reprocess those claims is a lot of work. And then we also wanted to talk about rates for behavioral health care. We believe that but only reimbursing 75% of the Medicare rates is not sustainable, especially when our neighboring states have a lot higher rates than Kentucky. This is a chart that we put together where you can see some common behavioral health CPT codes with our surrounding states. You can see there's only really one little section in Illinois. Doctors' rates were a little lower than ours, but all the rest of the rates are higher than Kentucky. Those rates in purple are actually rates they have different, what I would say, a different billing code for their behavioral health in those states. They use H codes. So we use the like codes, and that's what's in the purple. So it's not exactly 100% match. So you can see that. We also compared the states that DMS had chosen for their multi-state rate study that they started a year or 2 ago. And so we included all of those states as well and provided those charts to the MOAB. We believe Kentucky is just not keeping up with the cost of care. And back in 2005, so it's 20 years ago, associate level therapists made $78.40 an hour for an hour of therapy. Today, they make $78.67 an hour. That's 20 years later, making the same amount of money. And so basically our recommendation is that we increase Kentucky Medicaid behavioral health rates to 100% of Medicare. So Kentucky's can have access to care and we can afford to effectively hire good behavioral health professionals. And Medicare is known to be about 90% of the cost of care anyway. So when you start with 90% and then cut that by 75%, again, we're cutting the rug out from under our good providers. So that's what we presented. Questions?
Yeah, let's see if anybody has any questions. Most of you were on in the previous months when Victoria Smith reported that multi-state rate study, and we had lots of questions. We actually wanted a second phase of that, but if you'll remember, Commissioner Lee came on at our July meeting and said that they just don't have the man and woman power to do that, but that we will see the phase one wrapped up. I think there were 2 other states that are contiguous that were not included. And I think they didn't cover all the ABA codes that you had requested, Michelle. Is that correct?
We had requested that.
Yeah.
But I'm not sure that they were going to
include those.
Do phase 2. Basically, we were hoping that they would just complete phase 1, which was adding the other 2 surrounding states that weren't included, and to complete all those X's that were left blank.
Oh, yeah, that was it. Yeah. So the ABA, the ABA codes were going to be in phase 2, and that's going to be delayed.
Well, and I will say, if we increase the rates by 25%, all of those codes that were listed in those charts at least would still be under the state average for the surrounding states. So we're not even going to be at the surrounding state average of those surrounding states if we increase by 25%. So again, asking for 25% increase is really still putting us behind the 8 ball.
Yeah, that's sobering. You know, when Amy Stayed gave her presentation on Tuesday about the 1915 C rate study for the personal services workers, one of the points that she made is that by the time they had finished the study, even when the recommendation was made, several years had gone by. And if you just added the inflation in those ensuing years, whether it was 2 years or 3 years or whatever, you're already talking about increasing. You know, it would be wonderful if somehow we could get the legislature to budget at least an inflationary cost of living in those rates, you know.
Well, and we did use the $7 or $78.40 hour of therapy and used it in the consumer price index just to say what would that buying power have today, and that should be about 132 an hour versus the 78 in 20 years. So again, which is, you know, again, close to where we're getting with all those other states. So some kind of a cost of living or CPI does need to be considered for all behavioral or for all Medicaid services. But I think, again, using the Medicare as a balance, because I know that they look at those types of things for the Medicare rates. So if we use the same 100% of Medicare, that could at least be something. So those get adjusted when the Medicare rates get adjusted.
Right. Any questions for Michelle? And Barbara indicated that this, your report, Michelle, will be posted on the website along with the other BH-TAC materials from this meeting, so people will have access to it. And of course, in that public comment, you don't get any feedback or even any questions from the legislators, so you don't know if they heard it, if they were just trying to get out of the room because it's at the end of the meeting or.
And because that's a PDF that I think I forwarded you all this morning, the links at the top of the columns that I used on the presentation are not active. But if you'd like the PowerPoint presentation where the links are active and you've got PowerPoint, I'm happy to send you those or try to get someone a little more savvy to get the links in a PDF. That's probably what I need to do.
Yeah.
So I'll work on that. But if you want that, please feel free to reach out to me.
Yeah, why don't you put your email address in the chat if you don't mind, Michelle? That would be.
Yeah.
Okay.
That would be, yeah.
It's on the presentation as well.
Oh, okay. All right.
But I'll do that.
That'd be great. Thank you, Michelle.
Yeah, thank you very much
with that tomorrow.
Yeah. Any questions then? Okay. I forgot to tell you all, go back to the MOAB for just a minute. We will have another meeting of the MOAB on September 24th. That's a Wednesday, and they meet at 3 p.m. In Frankfurt, room 154. And then again on October 22nd. There is a chance that they're going to add another October meeting, and I made a request at the last MOAB meeting that they let us know as soon as possible. If you looked at an original information that I sent out about the November meeting, that meeting has now been changed. It's no longer November 19th, which I think was the week of Thanksgiving. It's now November 12th, which is also a Wednesday, but it's at 9 in the morning and not at 3 p.m. in the afternoon. All the other meetings have been at 3 p.m. in the afternoon. So just to let you know about that. And of course, you can watch those live and also archived on KET's been carrying those. And you can get the handouts and so forth. If you're interested in those HCB waivers, there were a ton of handouts that Steve and just blocked out her name. Steve and his fellow center had. Amy, yes, sorry about that. And I think your PowerPoints probably are up there too, aren't they, Leslie? Yeah. Okay.
Yes, and Dr. Schuster, we're just let you know, we're preparing responses now for several of the things in MOAB.
Okay.
Just don't have them completed yet.
Yeah, because there were a number of questions. Let me see if we have the folks on for our discussion about the credentialing of behavioral health. I had said we would start at 3. It's a couple minutes before then. Barbara, I was looking for Commissioner Marks from DBH. I think she put something in the chat, so she may already be on.
I am on. Unfortunately, I had to start my commute to Louisville, so I'm a little less able to present, but I believe Phyllis is on the call, and I had just posted the fee schedule earlier. Or sorry,
Yes.
I said the fee schedule. I just posted the SMI checklist earlier.
Yes, thank you very much, Commissioner. And is Phyllis Millspaugh on?
Phyllis.
Yes, I'm on. I'm here.
Okay, great. And then Sherry Staley from DMS is going to be part of the discussion, and she's on because we had her on earlier. So I'm looking for Karen Haskell, Barbara, KARYN HAS. Oh, you're there? Oh, okay. All right. Well, I appreciate, particularly Karen is between presentations at a conference, so we appreciate that very much. There was a preliminary discussion last meeting under new business about the credentialing of peer support specialist and some questions about that. So I think I'm going to start with Phyllis, because I think historically DBH, I think this is right, DBH was doing the credentialing of peer support specialists.
That's correct. We do provide credentialing for certified peer support specialists, which are the ones who are primarily providing behavioral health peer support or mental health peer support in particular. But there are other peer support specialists that the Board of Alcohol and Drug Counselors oversee, and those are the registered alcohol and drug peer support specialists. And therein lies the rub, I think, is the issue, the differences between those two types of providers, who manages them, and what impacts House Bill 505 had on the provision of services of peer support in what settings. I think everybody's aware that legislation was passed recently called House Bill 505 that made some changes to where providers could provide these services and what credential is the appropriate credential to provide those services. It made a distinction between the two types, registered being more substance use specific and certified being mental health specific peer support services. House Bill 505 required language to be developed in statute that stated fairly clearly that AODEs, alcohol and drug other entities, and behavioral health service organizations must only hire registered alcohol and drug peer support specialists, which has been put into statute, which created a lot of questions around the service being provided, as well as who could do that and the differences between the two. That statutory change did not really affect certified peer support specialists in any way. They are still eligible to provide services in those other settings. But when it came to the registered side, it kind of created some additional questions that I'm very happy that Karen Haskell is here, as well as Medicaid Sherry, to talk a little bit about the nuanced differences of that. But yes, we do the mental health ones, and we will continue to provide the certification for mental health peer support specialists, providing those services across the state.
And Phyllis, briefly, what are the requirements for those certified mental health peer support specialists?
These individuals must have lived experience in the service that they're providing. So a mental health condition that they have some recovery addressed in their world. They have to be trained by approved providers that the department has vetted. Those trainers submit a curriculum to us that we approve, and then they are eligible to go train on those topics. So certified individuals must go through one of those trainings. Currently 30 hours are required to become a certified peer support specialist. They have to be over the age of 18 and have a high school or GED education. So those are the basic requirements for certified peer support specialists.
Do they have a requirement for so many hours of supervised experience before they can get certified?
They do not have that requirement in our language.
Okay. And what's the requirement once they're certified? Are they required to be supervised by anybody?
Yes, they are required to be supervised regularly. I'm trying to recall the actual numbers, but they have to be supervised by an individual who's listed in the regulations. So there are 3 regulations currently that we manage for certification: 908 KAR 2220, 2230, and 2240, which are adult peer support, family peer support, and youth peer support. And each of them have language in those regulations of available or eligible supervisors, which are listed in the reg. Essentially, it's a licensed individual with some experience in the mental health field. They're all pretty much identified specifically in the regulation of who is eligible supervisor.
Okay. Is there a fee for them to be certified?
We do not charge a fee for certification specifically, but trainers do provide fees to receive the training, and it ranges anywhere from free to $350 per training. I mean, it goes across the board. We don't really control that amount. There are many entities that really that's their primary work is to train individuals, and so their training fees are something that they develop. We do not manage those.
Okay. And where can they work? Is there any stipulation about where they can work?
Well, they cannot be employed in AODEs and BEHSOs to provide substance use services. So that's clearly identified in the statute. In other settings, however, certified peer support specialists are fully eligible to provide those.
So they could be employed at a BHSO, but they cannot provide substance use services.
That's a tough question to answer. Laura, I'm seeing Laura in the chat have some additional information on continuing education hours. Laura, could you tell us the group with the continuing education hours are required? Laura, can you hear me? Okay, she must be having some technical difficulties. They do have continuing education requirements. I apologize for missing that component. Certified peer support specialists are required to annually have 6 hours of continuing education, 6 to 10 hours, I believe, annually that they must submit to our training record information system, or TRIS, to keep track of their regular updates of education. They do get recertified and submit that information annually. And we have a group of folks in the department who manage those recertifications. As to where they can work, back to your question, they are not eligible to work in AODEs and BHSOs. Right now, the statute says that those entities can only hire registered individuals. Registered individuals are only eligible to provide substance use related services. That's what they're trained to do. So I would imagine there are individuals in those settings who are certified, but they cannot provide substance use services. And so the question is whether or not they can stay in those spaces. And that's a question that we're trying to get a more consistent answer from. And I'd love my colleagues to help with that answer.
Okay, so that may be a DMS question. Thank you, Phyllis, very much for that.
Phyllis and Sheila, can I say something here? I was trying to find where to raise my hand, and sorry I couldn't. It's Kathy Dobbins. But Wellspring has peers, certified peer specialists, and have had since before it was ever even a Medicaid billable service. But now it is a Medicaid billable service. We are a BHSO 1. We are not a substance abuse BHSO. So, I mean, there is a distinction there, and I just wanted to mention that, Phyllis.
Yes, what you're referring to, Kathy, are the many, many nuances and wrinkles that House Bill 505 brought into the spotlight. The tiers for BHSOs are things that we do not manage. I think that definitely is an area that Medicaid might be able to respond a little more accurately to than are we.
Kathy, there shouldn't be any changes to the BHSO 1. It would be for AODE licensure agencies. So if you are a BHSO 1 not providing SUD services, then your adult peer support specialists that have lived experience with the populations you are using them for, there should be no change.
And that's what I assumed, Sherry. But I wanted to clarify that for Sheila, too. That there's a difference in terms of what the area of specialization is for BHSOs. Some are more substance use focused, and some are more mental health focused.
Yeah,
Right.
Which is hard to separate, as we all know, because they don't come that cleanly. But yes.
Yeah, unfortunately, as I'm looking at the language in 505, section 11, 1A, it says drug treatment entities, which would be your AODEs, and behavioral health service organizations only employ a temporary alcohol and drugs. It doesn't make a distinction in the bill language between a BHSO one and the other BHSOs.
No, you're right. It does not.
And that is a concern. You know, all of our peers have the lived experience of serious mental illness, which makes them, you know, have a very different focus than substance use treatment program peers.
The registered peer support specialist is only available through the Drug and Alcohol Licensing Board. And so your peers with SMI aren't eligible to get registered through that board because they don't have the sustained recovery and lived experience. So that tells us that it only applies to SUD. And that is the way we are interpreting that care.
Gotcha.
Okay.
So it's the difference in title between a certified and a registered or temporarily registered is the other thing. Okay.
Sheila, this is Susan with 7 counties, and by virtue of being a CCBHC, we also are an AODE, and we've been getting mixed answers or information on when individuals are co-occurring and how the MCOs will interpret in someone that's co-occurring. So if a peer is a certified peer predominantly treating SMI, but the individual that they're treating also has some substance use and those co-occurring discussions come up as part of treatment, how does that impact related to this regulation?
And who's the determiner of that, Susan? Thank you very much for that question. Is that a DMS question, Sherry?
And I guess the question to specify that came up is if a claim goes to an MCO with the primary diagnosis of mental health, but a secondary, tertiary diagnosis of substance abuse, and they're getting a peer support service, would that be an issue?
You know, Susan, you and I have been around long enough that this is like something that we've talked about for decades. People are people, and more than half the people with serious mental illness have a substance use diagnosis, and it makes no sense at all that would be an issue to me. I mean, I can't imagine that would be an issue for the MCO.
Well, but we got correspondence that told us that our peers, if they were treating co-occurring, had to have both certified through DBH and registered through the alcohol board. And so we need to clarify that. That's really important information for us to understand.
Back to the wrong door.
Who did that guidance come from, Susan?
I think it was on the FAQ that came from DMS.
That actually came through, in addition of our department sent that out after we talked. I mean, this was a collaborative response, Sherry, that we kind of agreed on in terms of how to tease those out. So we did send out communication that reflected, if you're working in AODE and serving and billing for Medicaid, you had to have a registered individual working there. If you're billing for Medicaid and a BHSO and providing mental health services, you had to have a certified person. And if you're dealing with an individual who might have a co-occurring diagnosis, you either had to have both of those certifications or licensures, registered or certified, or have two different individuals providing those services. That is what we sent out. So I'm going to own that. But it was after discussion around that. So I'd love to be able to clarify that, because I know that caused a lot of questions.
I would echo what Kathy just said. It's that word treating. So you might have an SMI individual that the peer is treating the SMI diagnosis, that's where their lived experience is. But in one session, their use of substance comes up. They have a diagnosis, a secondary, tertiary diagnosis of substance abuse, but that peer is not predominantly treating that. But to say it never is discussed, that's probably, a false statement. So how we want to be in the right. We want to make sure our peers aren't going to get denied services by the MCOs when a claim comes in with that diagnosis on it or something like that. But it's also a lot of hoops for our peers to jump through to have both certifications and follow all that supervision and requirements to go with it. So we don't want to go over what we need to do. And so we're just really unclear on what does that mean.
Yeah,
Treating
that's
co-occurring.
really, it just seems hard to believe that they could make the requirements, which are pretty stringent for our peers with serious mental illness already. To double that, if a client happens to have a co-occurring disorder, makes no sense at all. You can, one way that I've always looked at this is, if a person has a serious mental illness and they're using substances, it has an impact on the serious mental illness. So, they are related and both need to be addressed in order for the person to have mental health recovery.
Excuse me, Kelly Gunning has her hand raised.
Yeah.
Hi, I've had my hand up for a minute, but I just
Sorry,
wanted
Kelly.
to say that the training itself has been all over the place in the last few years. First, we were doing, SMI, then it was the strong emphasis on including SUD. And so then they were trained in both, supposedly certified in both, according to us who have been doing it for a long time. I will state that we don't bill Medicaid for any of our peer support services. We are grant funded through the entities that we use them in. But I'll give you our mental health court as a prime example. 89% of our clients are co-occurring. And all of our peer specialists that were trained when they were having the dual emphasis on both SMI and substance use are duly trained. And then they go get their training every 6 months, every 6 credits every year for their continuing education. And we do the mixed bag of training at our consumer conference every year. David Rigsby and Amber Collins and I have been working really hard on this because it's very, very difficult to decipher and to say who can do what. And Susan and Kathy both gave excellent, examples of the fact that these are complex human beings with complex issues. And almost, like I say, to the T, always there's a co-occurring thing lurking in there, as well as trauma. So we've trained all of our peer specialists to be, fluent in all those languages: trauma, co-occurring, and SPMI, and just substance use disorder. So it makes it really difficult. And the supervision is a whole nother nightmare. It's a whole nother thing of who are their peers? They are not clinicians. Why are they being supervised by clinicians? They are not doing clinical work. And if they are, they shouldn't be. So there's a whole lot of questions around here. And David and I and Valerie have been really trying hard with Amber to work through them and get answers, but I don't think we're moving in the right direction here. Just
Yeah,
are we
going to narrow it down to, peer support specialists are only going to be able to work with people with trauma if they have trauma? Are we going to narrow it down to folks, that only have schizophrenia? You can only work with people who have schizophrenia.
That is the language in the regulation currently, that they must have the lived experience of the population that they are treating. And so that would go back to treatment plans, what is the role. But I will say for Medicaid billing, the supervision has to be done by an enrolled Medicaid provider. And it's clearly just a mechanism to get the billing to go through. Peer support individuals do not enroll in Medicaid, neither do associate level providers. And so in order for their billing to go through, it has to go through an enrolled provider. So that is the function of billing supervision in Medicaid.
So what is the billing supervision at this point? I know we don't bill, Kelly and I, but I mean, I'm just curious what the billing supervision
This
is.
is why, Valerie.
Well, they have to have a one-on-one meeting with them monthly to go over every case and talk about the disposition of the case. They have to co-sign notes. They have to work on the development of the treatment plan, including that individual. So those are laid out in the regulations as well.
I'm going to stop for a second because I want to bring Karen Haskell in, and you've been very patient, Karen, because obviously you've got the bulk of this in terms of the timeline with 505. So can you tell us what you all have been doing and what you're trying to do to get people who clearly are covered by 505 through the process?
Yeah, we've had a significant increase, obviously, in applications for peer support specialists. And we are moving through them as quickly as we can. We did decide to grant our statute and regulations talk about 40 hours of training in the 4 core functions of drug and alcohol peer support specialist. And we did decide to allow the 30 hours of training that's been done by other organizations, including the Cabinet for Health and Family Services, as a part of that 40 hours as an exception right now to allow people to have that training so they don't have to literally start all over with training, because there really are not even enough training opportunities available to meet the needs of all of the folks who are applying. So we did make an exception on those 30 hours of training that they've already had. So it will count toward the total of 51 hours, even though those hours may not technically be in exactly the domains. We felt like it was close enough that, they'd had significant training opportunities. So
does that 10 hours you're talking about, does it have to be specific to SUD?
Well, if they were doing the standard 40 hours of training in the core functions or the domains rather, yes, they would all be in SUD, but we're saying those other 30 hours of training are close enough that will waive that and allow those 30 hours of training that they've had.
But
We just wanted.
Are you talking about the certified or the registered?
Yeah. No, we're talking about the registered.
We're talking about. I'm talking about. Okay. The Alcohol and Drug Board only does registered alcohol and drug peer support specialists. We do not have a co-occurring peer support specialist that is credentialed under the Alcohol and Drug Board. Just give me a second, finish my sentence. The ICNRC, the International Credentialing and Reciprocity Consortium, is the national organization that we are affiliated with. And it's international and includes all of the military and a number of other, in 48 states. And they are the organization that creates and implements the testing that we use for peer support specialists. Well, for all of our credentials, they are the ones who have done all the work on validating the testing for all of the alcohol and drug credentials. So we have an obligation to stay in line with the requirements of the ICNRC. The other thing that being a part of the ICNRC does is give folks reciprocity with all of those other organizations. So if they're credentialed in Kentucky, they can easily have reciprocity in Indiana, Ohio, Tennessee, etc. But the main point is the testing. The ICNRC is considering at this point a credential for co-occurring peer support. They have not yet developed all of the scope of practice for that. They also dictate the scope of practice for our credential holders. They've not completed the work on the scope of practice. They've not completed the work on all of the knowledge base items that will be required that then will move into the testing piece for a co-occurring peer support specialist. And what Kentucky is working on, and the conference that I'm at right now has a session this afternoon or tomorrow on the supervision of peer support specialists, because right now, all of our supervisors are trained in clinical supervision. Clearly, this is not a clinical function. So we have developed training for peer support supervision. We can and probably will move toward aligning with the ICNRC when they have the co-occurring peer support credential. But right now, the ADC board does not have the infrastructure to support that. We don't have the supervision training. We don't have trained supervisors. We don't have training opportunities that are sanctioned by our board for co-occurring peer supports. And I think it's not in our best interest to start offering a credential that doesn't have the infrastructure to support it. So that once the ICNRC has developed those things, we will then work, and all of that has to be in statute and regulation. So that's not going to happen quickly.
But the
But we are
supervision,
moving in that direction.
but it would be your board, Karen, the Alcohol and Drug Counselor Board, that would grant the regulation, would regulate or grant the certificate of regulation or whatever you want to call it.
Yeah.
And you all would do the supervision then, even of the co-occurring.
Well, I don't.
I'm asking, I guess.
Yeah, I don't know, because Phyllis and I have had enough trouble trying to figure out where we are right now, let alone figuring out where we're going to go next year, to tell you the truth. We're having a hard enough time getting our arms around the scenarios that we're currently presented with. And we've not gotten that far down into the weeds on that.
It would definitely require Medicaid approval and, you know, alignment with their billing requirements and the eligibility of the supervisors to supervise. So all of that, all of those things would have to align to establish a co-occurring position under that board, which would definitely clarify things. But as Karen said, you know, that's not going to happen soon. It's going to take a while. If we're going to develop those psychometric properties for the testing, that takes some time to do. So we don't have a quick fix on this, unfortunately,
Phyllis,
to address all the questions.
Yeah, I forgot to ask you, Phyllis, does your certification require a written examination?
It does. It does have an exam. Yes, the trainers who are approved to train are required to test the individuals who have accomplished the training, and they must pass at 85%, I believe. And then they would be eligible to become certified under our regulations.
And is that examination the same used across different trainers?
I would say no. I don't think there's not standardization across trainers at this point.
So
which
Sheila,
is an issue that we're trying to address, obviously.
This is Susan at Seven Counties again. I mean, I think this just highlights for us that our concern is will the MCOs interpret differently from any guidance we're getting from DBH or DMS? So that's why we're asking for DMS and or DBH to take a stance on co-occurring that is consistent with the providers and the MCOs, so there's not any surprises in the future when we go to bill. I think the other key thing that it's important to understand from an advocacy and regulation point of view, I want to add that Karen with the board has been extremely helpful in guiding us through this, and so we appreciate that. But of course, she doesn't have all the answers that are broader beyond what their board does. And one of the challenges that we're running into is the Kentucky Board of Alcohol and Drug Counselors requires that a peer receive a temporary status prior to becoming a full registered peer. And I understand all that. I understand what's behind that. But the dilemma is the Department of Medicaid does not recognize that temporary status. So that leaves providers in a situation that all of our peers for a period of time will not be reimbursable while they move through this board process, which leaves minimal sources to provide services to that SUD population. And I think that's a dilemma that we certainly, as advocates and providers, need to recognize that we've got a disconnect in these two regulations that is going to be harmful to providers and individuals seeking services starting January 1st.
Yeah.
Well,
We don't disagree at all with you on that. I mean, I think Karen and Sherry, all the three agencies that you have here today have talked a lot about these very issues and the impact that 505 has led us to. I will say that please know that these are not decisions that any of the three agencies here made. We did not create the legislation. It was sponsored by Representative Mosier. And we have had conversations with the representative around these issues to try to address what this has caused. She has not yet made any firm decisions, but she was very open to hearing about the concerns from all these different layers that 505 has created, and recognize that she would benefit from more collaborative response from all three agencies here in the room. And I do believe that they will, moving forward, will have that opportunity. And it's possible that we'll see something in the next session. I can't promise that, but I know that she's interested and is very aware that there are problems with this, and it's causing some significant problems for the providers, but more specifically for those who need these services. We want to make sure that they're accessible and available as they're needed, and this does provide that potential problem. So there are things in the future that we're trying to address, but I want to say we all recognize that it doesn't fix things right now. And we are trying to figure out what path forward works best, which is why you're seeing some of the communication that you see, and why it's been difficult to answer the very nuanced questions that you guys are bringing into the room, because there's so many wrinkles here. And I just want you all to hear that we recognize that and are trying to address them, but it's not an easy solution when we have three different agencies who have different responsibilities to figure out the universal path forward. But I will say that we are attempting to find that pathway, and we'll communicate with the field as much as we possibly can, as quickly as we can. But right this moment, we don't have a good fix. I'll just say that.
Yeah, I want to echo what Phyllis is saying. I feel like we've had really terrific conversations. We didn't want this. We didn't support it. We don't want it now. But here it is. And we have had many conversations with the Cabinet for Health and Family Services and with the Public Protection Cabinet, because we're part of the Public Protection Cabinet. And we've had many conversations about trying to find a path forward that is the least painful for everybody. But we recognize that this is really puts everybody in a very difficult position. And the folks who suffer, obviously, are the clients who need these services. And I wanted to add, Phyllis, you may not be aware of this, but in addition to Representative Moser, Representative Flannery has reached out to us. and has set a meeting and then had to cancel the meeting. So he has submitted questions to us about 505 and about this whole scenario. And I responded to those questions, of course, with our legal counsel today. I don't know what will happen with that, but I do know that it's a conversation that is broader now than just with Representative Moser. So there are apparently other legislators who are aware that there's some heartburn with this particular piece of legislation and what's going to happen in January. And again, I have no idea where that's going. I just responded as honestly and clearly as I could to the questions that were posed to us in the last couple days. So, you know, it is apparently a bigger conversation. I don't know if that's good news or bad news.
Well, I do know as recently as yesterday, both Steve and I had a very brief discussion with Representative Moser after the Moab meeting, and she is very aware of these issues. She's heard those before, and she is very open. And I had told her a month ago that we were going to have this discussion at the BH TAC, and she said, I really want to hear how that discussion goes and so forth. So, you know, I think she is very open to trying to fix this. I think we need to keep talking to each other because we need to keep the people who need the services first and foremost. And then we need to figure out how to get those services to them so that the providers can get paid, and so that there's a place for the peer support specialists, who I think are one of the most positive additions to our behavioral health armamentary in the last, 10 years or so. But make sure that they know and are very clear on, you know, where they belong and what they can do and so forth. Kathy, you have your hand up.
I did just want to add a couple things. You know, the term co-occurring is that's a broad net. And, you know, when we talk about certified peer specialists, we're typically talking about somebody who has a serious mental illness like schizophrenia, bipolar disorder, other psychotic spectrum disorders, who understand what it's like to be symptomatic, who understand what it's like to take medication, who understands what it's like to have an involuntary hospitalization. You know, that's very different than somebody who may have a trauma diagnosis and a substance use disorder. Now, I'm not saying that trauma disorders are not a grave concern, and sometimes people with serious mental illness have a trauma disorder on top of a serious mental illness and substance use disorder. But we have different specializations here across this group of providers on the call. And so just talking about co-occurring has to be nuanced out a bit more. That's all I'm saying. And then the final thing I would say is that I do want to just add, I think somebody's made a point here about supervision, Melissa Hopkins, for peer specialists. But I want to emphasize certified peer specialists, and a licensed clinician has to sign off on every single billable note to Medicaid. I'm pretty sure I'm accurate about that. I'm constantly hearing about, you know, our highest paid staff spend hours and hours providing that level of supervision, and they take it very seriously because it's on their license too. So they are getting a lot of time and attention in order to be able to bill Medicaid. So those are my only points.
Yeah, that reminds me, Karen, I had one question in 505 about supervision, page 8, and you talk about that they would have to work under the direct supervision of, and it says a certified alcohol and drug counselor, a licensed clinical alcohol and drug counselor, and then the new language is under the supervision of the board. a
But-
registered alcohol and drug peer support specialist, da-da-da-da-da-da, and I didn't know what that meant.
Well, I think, well, there are a number of language problems with 505.
Okay.
You just found one of them, but it should say board approved supervisor. Yeah.
Okay.
The other thing that 505 says is that a registered alcohol and drug peer support specialist with 2 years post registration is eligible to supervise uh, other registered alcohol and drug peer support specialists. Well, we really don't have, the ADC board does not have a mechanism for approving that supervision. And across the entire state, we only have 24 registered alcohol and drug peer support specialists. So firstly, there aren't any people to actually do that work. And secondly, we don't have a mechanism in place to certify or credential those folks to do supervision. And as I said, the first training that we're doing related to peer support supervision is happening tomorrow here at the CAP conference. So, you know, I just don't know anything. I don't know what we're going to do about that. But you just need to put the word approved in there, Sheila. That
All right.
fixes that sentence.
I had never seen supervision that was by the board. And I was like, yeah.
No.
And you know that I've cut my teeth on all the licensure statutes.
Oh, I do.
In the state. So I've been doing this a long time, and I was like, whoa, what is this?
I do. And this reminds me of back in the days when we were first creating the first certified alcohol and drug counselor piece of legislation. I don't think I've seen such a mess since that was going around. So,
Right. And I've worked with you all on that. So
yeah, exactly. This feels like PTSD.
Yeah, I think the good news is that what's come clear is that the 3 agencies, the board, Alcohol and Drug Counselor Board, the Medicaid and DBHDID are working together, and that's absolutely good news.
We absolutely are.
We obviously have lots of questions from agencies about what they've been able to do historically and what, you know, it looks like going forward. And then the immediate questions that Susan Rittenhouse and I'm sure other CMHCs and certainly the CCBHCs have about how to build those services. Phyllis, I think it was in the chat, but somebody asked if you could put a link or send that document to Barbara after the meeting so we could all see that, the FAQ?
Well, yes, I can do that. Absolutely.
Okay.
I think also in the chat was dropped what we call the visual guide, which is another piece of the messaging that we sent out along with the FAQ document that sort of walks you through at least how it's being currently interpreted as best we can. So that's also available to folks. And I want to say too that, you know, when you talk about questions that are being raised in the room, many of them, we're really aware of that. We already have like 10 pages of questions that have been generated and submitted to us over the last few months, identifying all of these different areas that are of concern to us all. And Laura, if you don't mind, would you mind putting that email address in the chat so that folks who have, you know, specific questions can continue to contribute to those? You know, we are collecting those. We are trying to organize them in a way that, you know, when we're able to have concise, clear answers, we can do all of those. We do have efforts underway to try to address these questions. That is a partnership among the 3 agencies, so that we're at the very least we can try to, among us, provide some clarity. I want to reinforce though that this is a legislative issue more than it is anything else that can be addressed. We hope will be addressed. And I think the advocates in the room who are so passionate about it have the ability to communicate with individuals to share their concerns. And that is always the best way to get the information broadly applied and addressed. I would just suggest that those of you who do reach out to advocate, that you suggest that the 3 agencies are brought together for these conversations so that we can all provide the different perspectives that are important to these decisions, so that whatever does come out is one that does meet all of the criteria that we all have currently that we have to implement.
I think that's a great idea, and I very much appreciate all of you making the time, and Karen, you're particularly making the time between presentations at the conference and so forth. I'm going to keep this on, so it'll be on our next meeting, which is November 13th. And I would like to, I know both Steve and I, who have done a ton of lobbying, not advocacy in Frankfurt, would certainly volunteer to meet with you all or to get some ideas, because I think you know, we may have ways of communicating with legislators, and the more we can communicate from all three agencies, I think your point is well taken, Phyllis. So let me offer that. And then there's some good links in the chat as well.
Right, but in the chat, you have the documents that you were asking for a moment ago. All of those are what were distributed previously.
Yeah, it's very, very helpful. And thank you, Kathy and others, Susan that raised, Valerie and Kelly raised some really good questions and so forth. This is obviously not settled, but I think we all have the same idea, and that is to make sure that we get the right services for the people that need it delivered by the best people, and that people get paid for the work they're doing. The recording of this meeting is posted to the cabinet website, right, Barbara? And there's a page
Yes.
for the BH TAC. So
Yes.
there is a recording, and then we will get actually a court report of this meeting. That will be many, many pages long. It's not the easiest thing to read, but that is going to be available. So anybody that missed the meeting or wants to go back and check anything. And I've forgotten, Barbara, it takes a little bit of time for you to get all of that posted, I think.
Yes, it does. It takes a little bit of time.
Okay. So maybe this time next week, is that reasonable? I just don't remember.
I believe it would be maybe this next week, early next week.
Okay. If you'll let me know, Barbara, when that gets posted, because there are a lot of people that get alerts from me about the BH TAC. And my email is kyadvocacy@gmail.com, which is real easy to remember. So if you're not getting material from me about this, I'm happy to add you to my ever-growing long list. So thank you all. And Karen, especially thank you for making the time. Phyllis, this is super helpful information. Sherry also, and again, great questions. So we will, if you all might mark November 13th on your calendar, we'll reprise this discussion and see what kind of progress we've made at that point. Okay?
Well, Dr. Schuster, I think we're all glad that we had the opportunity to at least share some perspective on what's happening. And I think all of us are in agreement that we want to work together to move forward so that we can address how to best fix the concerns that are that were resulting from that bill, so we can have better services for the clients who need them. So appreciate that opportunity. I'd be happy to come back in November, and hopefully we'll have better information, you know, some updated information that possibly could be shared. So that would be the goal. So thank you.
Yeah, absolutely.
Thank you.
Yeah, thank you, Karen. We've tried to run the BH TAC meetings in a way that really is a problem solving and a coming together. You know, we're all basically here for the same purpose, and that is to make sure that people get the behavioral health services that they need. Right. And so, you know, we want to make sure that happens. So thank you all very much.
Thank you.
Okay.
Thank you.
The update on credentialing new behavioral health providers, that was Mandy who brought that up, and she's had several discussions with DMS, and they have been able to work through those issues. So we're going to skip that. can we get an update on the 1915I, the SMI state plan amendment?
Hi, Sheila. It's Ann.
Hi, Ann. How are you?
I'm feverishly working just like everybody else. But I'll try to go fast. I know we're running out of time, but the regulations, I saw that Jonathan Scott was on here. They cleared their final committee back in the end of July. So all 1959 regulations are live and moving forward.
Right.
The next thing on provider enrollment, we went live and started the process July 1. So it's
Right.
been moved kind of slow, but what we've done is everyone that had started the process, we had sent individual emails about, we have started we've sent emails to them about office hours, which we started this week. So every Monday and Wednesday from 3 to 4, we have a Zoom link. You can find it on our website to register, and you just pop in and we answer questions anybody prospective provider might have. If you prefer to have a one-on-one, we will also schedule one-on-ones with individuals. But we had 13 different individuals at Monday's office hours and had some really good conversation. And then yesterday at Wednesday, there were 15 individuals there, and
Right.
the team had really good questions and conversation there as well. I do want to tell you that we also have had a couple of one-on-ones with providers. We can see that we have 101 different individuals have downloaded the packet, certification packet instructions. We've received 6 provider certification packets, which are in the review process. So some of them we've done the initial check that they have all the documents, and then we're in the formal review of making sure they comply with regulatory requirements. And we do have our first site visit scheduled on the week of September 22nd. So that is the first step towards, certification and enrollment into Medicaid. So
That's
it
great
has
news. Yeah.
it has been a little, slow, but we're trying to do as much as we can to help any provider that wants to be, a 1959 RISE provider. And then the last thing you asked about was participant interest. And I would say we are addressing around 6 inquiries weekly. Some are by phone and some are by our email box. So we've kind of started an interested parties list is what I like to call it. I don't want to call it a wait list because it's not a wait list.
Right.
But when we do get started with individuals and being able to assess them, we will contact those individuals on that list. And so far we have about 30 on that list. So we are seeing interest, but we don't want to lose anybody, along the way. That's
Right.
why we're
Right.
tracking names and phone numbers and that kind of thing.
Ann, can you put in the chat the phone number and the email address for participants?
I sure will.
Or
If you'll let
go
me,
on
I'll do
and
that when I stop talking.
Okay, go on and do that for providers too, but I keep forgetting to send out. I know I still get calls from family members around the state, and I'm sure there are NAMI groups that are getting those calls as well.
Sure.
So
And look,
that's
I'm looking for my little book. I have it all written down in to be able to
right.
do it.
All right,
And
thank you.
that's just a quick update. Thank you.
All right, thank you. Angela, are you doing the status update on the reentry waiver?
I don't believe Angela was able to be here. I can give that update really quickly.
Oh, thank you.
Sure. The work streams continue and are ongoing. There are key work groups right now that are focused on technical, pharmacy, and case management. And this includes policy development for each of those areas. And we will continue through this month in October if that's needed. The project team is also working actively to ensure system alignment across all platforms with all vendors. And so full end-to-end testing, both internally and externally with Justice Partners, is still scheduled to begin in October and run through the end of Q4 2025. This adjustment is necessary to ensure that all requirements are met and in place to support the data sharing. That's a big part of monitoring. And then for provider enrollment, DMS continues to work with Justice Partners and MCOs to streamline the provider enrollment process for DLC and DJJ prescribers, ensuring that all individual prescribers and practitioners are Medicaid enrolled. And the provider trainings for billing, medication, prior authorization, case management delivery, including MCOs and Justice Partners, and readiness will occur late fall and into the new year with full delivery of services beginning 4/1/26. So still implementation 10/1, but still working through some of those testing and training pieces, enrollment pieces. So the expectation is for all of that to continue with full service delivery on 4/1.
Sherry, this is Leslie, Dr. Schuster. I just would like to add too that we've been afforded a really cool opportunity. If you remember, we started with a collaborative with just a few states scattered around that were kind of growing or moving through this process like we were. We were a little bit ahead of some and maybe behind with one or two others like, California and those. But we've been asked to come to Utah in October, and our sister agencies are going with us as well. So it's kind of exciting. I think Van Ingram will be going with us. We also have DJJ going with us, and Department of Behavioral Health, Intellectual and Developmental Disability. And then Angela and I will be traveling. And I think we're going to wrap up that collaborative. So that's been a really good opportunity for us, and we're looking forward to it. And we're all also taking a tour tomorrow to Luther Luckett. So I've not been on a tour for a long time since I worked at DBH. So I'm excited about going again.
Yeah, that is exciting, Leslie.
Yeah.
Great. Yeah. And Sherry, thank you. We haven't had a real clear kind of, here's where we're going to be up, really, really up and running. So that's helpful. And I know there's been a million pieces to gather together. So thank you very much. Do we have anybody with current waiting list numbers, Leslie?
Yes,
Yes.
ma'am.
Oh, okay.
Dr. Schuster, hi, this is Carmen, and I apologize for
hi,
not being on
Carmen.
camera. Hi there. I've been having issues, so please accept my apologies.
No
I know we're
problem.
running. Thank you.
I saw you on Wednesday in person, so.
Yes, ma'am. It was lovely to see you in person. I know that we're running short on time, so I did just drop the waitlist numbers in the chat to have there. I can run through them if you'd like.
Yeah, I
And then
don't see him in the chat.
Yeah.
Do you see him, Barbara? The last thing I see in the chat are from Ann Holland.
They're up a little ways.
They're there. They're in
Oh, they're
between
there.
my,
Okay.
they're in between what I put.
All
Yeah.
right. Yeah. Okay.
Okay.
Got them, Carmen.
Okay, thank you. And then with regard to the ABI and therapies, obviously there aren't any changes to the therapies at this time in the ABI waivers. As you all know and have been tracking, we do anticipate a change at some point, but we will make sure that everyone has ample notice and plenty of time to pivot and work around whatever those may be, but no changes right now.
Okay. I have to get out my magnifying glass to look at this chart. So let me ask you, do you have both duplicated and unduplicated numbers in there?
Yes, ma'am. The total on wait lists duplicated is 18,826.
Okay.
Unduplicated is 16,382.
Wonderful. Thank you very much, because that question comes up, and I was estimating that we were up to 16,000 and over at this point. So that unduplicated is 16,382.
Yes, ma'am, that's correct.
Sorry,
Yeah.
if I may, you heard Carmen and I present at the Moab the other day. Just to let you know, that's we've got 14% of duplication that we've identified. We've got let's see, 86% of these members also have Medicaid already, so they're receiving state plan services. And then Carmen, was it 30-some%?
38%.
38%.
Yes.
Sorry, I don't have it in front of me. 38% are on a wait list, plus already been allocated to to go forth or receiving in another waiver. So I think somebody mentioned earlier. So for example, somebody may be on the Michelle P, but they want to get to SCL at some point. So they might be on the Michelle P now, but wanting to get to SCL because it has a residential component. I'm just giving you an example.
Yeah, yeah. That's helpful because that kind of describes who the folks are.
That's correct. And then I always remind everybody of those 86%, of course, children are going to get anything outside of state that state plan doesn't cover through EPSDT, another benefit that we have.
Yeah. All right. Thank you. That's very helpful. Are there any recommendations to be made to the MAC? I don't know when the MAC's going to meet. Any from our voting members, any recommendations for the MAC? All right. The MAC meeting is up in the air because the July meeting and the September meeting both are now canceled because it's taken a while to get the BAC, the Beneficiary Advisory Council, up and running, and it has to meet before the MAC can meet. So DMS and their contractor are working very hard. I will tell you that there are 15 members that have been appointed to the new Beneficiary Advisory Council. 10 of them are current Medicaid members and 5 are family guardian or caregivers. And then 7 of the BAC members have been appointed to serve on the MAC. And that's a requirement also from DMS. So they're doing orientation. I went to the one, was that just yesterday? It feels like
yesterday.
Yes, it was yesterday.
Yeah, where we got the background and how they would both operate and so forth. So the MAC has been a little bit stymied. We're really out of sync with our regular, bi-monthly meetings at this point. And hopefully we should have a meeting date, I would say in October. I think most of the dates that were sent out were in October. So we will keep you posted. Our next BH-TAC meeting, though, will stay on a bi-monthly schedule, is November 13th, and again from 2 to 4. We'll try to set the 2026 meetings, but we'll need to know when the MAC meetings are. And I'm hoping at the first MAC meeting in October that we'll be able to set a calendar for the 2026 MAC meetings. I'm sorry if this is alphabet soup and get you hungry also talking about MACs and so forth. No eating at those meetings. Well, yes, people are on Zoom so they can eat, but anyway, and I'm sorry that we've gone, actually not too bad for all the discussion that we had. Is there anything under new business that anybody wants to bring forward? Okay, and do we have any formulary issues? We always ask that under old business, and thankfully we have not had any issues, Val. I don't think we haven't had anything really come up.
I'm just hoping availability will be available.
Yes, well, that would help. Yes. So we have some things that will carry over to the next BH-TAC meeting, including the ongoing discussion around the peer support specialists, and then a look back on prior authorizations and audits. But there probably will be some other things. So there being no other business, I would entertain a motion to adjourn. Come on, Val, don't you want us to adjourn?
Let's go. Let's go.
I usually do that by acclamation. Do we have a second? I don't know if we've got any more voting members on. Yes, Tara. Okay. So we will adjourn, and I thank you all for your participation. And I think it was productive discussion. So hopefully some changes can come about.
Thank you.
Yeah. Take care, you all.
Thank you.
Bye-bye.
Bye-bye.